So thank you all for coming. It's great that you're here. And we actually had 246 people register, which was great. So there's obviously a lot of interest in the subject. Obviously, we hope as many as possible are online. And for those who are online, please do make sure, as we're going through the presentations and the discussion, save up your questions for some time at the end, which we still will have at the end, to have a really, really good conversation about some really, really, really issues that are facing not just the UK, but the world. So I think most of you probably know me. I'm the one who's been sending out all the emails to remind you to come on time to pass through security, as well as chairing and working with all my dear colleagues who will be on the panel shortly. So just a few words now. Provider Health, of course, as many of you will know, I also run Business for Health, and many of the partnerships that we see on the screen have all really been involved in this whole sort of theme of linking health and economic growth. What I have been seeing more and more, and I spent a lot of time, traveling abroad, wearing my different hats, is that the socioeconomic case has just become so important for everything that we are doing. For obvious reasons, I think what we're facing in the UK with our economic growth sort of being hampered by chronically growing populations, the workforce and activity crisis. But that is not, we are having this all over the world, in many parts of the world. And of course, we've infected the world with our Western disease epidemic in some of the developing nations, even the Middle East are battling with this. And we know that, for example, in the United States, who spend 18% or even more of their GDP on healthcare, Trump was trying to deal with that as well. We are seeing even declining life expectancy. And this is, crazy when you see the resources and the money that is spent on the healthcare system. And you've got those sort of the outcomes. So I think the outcomes piece is really, really important to focus on how we actually really improve health. And we're seeing more and more the evidence showing is so linked to our individual wealth, our economic growth as nations. So it's a really, really important topic. So I'm glad Longevity Week put that in the spotlight. Of course, we have been partnering with the Longevity Forum Longevity Week for ever since it began. I'm wondering whether we should call it the UK or London Longevity Week, because of course there are longevity weeks all around the world. So and I certainly spend a lot of my time at these conferences, and I'm starting to see, fortunately, people starting to come out of their silos in aging research and longevity research and actually really trying to embrace the economic realities of actually what we're really facing as a nation. So we'll come on to that in a minute. So we've got some fantastic people who are here, and thanks, very much to Richard, obviously at Aging Research UK, who's been our stalwart partner throughout, all this. So we're going to go through, and if we can just click on to the next slide, the agenda, just to briefly cap through the agenda. So I'll ask David Calder to say a few words in a moment, who, of course, UKRI, they have been an absolute, and such a critical partner in all of this, and also indeed working with my colleagues at the National Innovation Centre for Aging. I used to be very involved in the Healthy Aging Industrial Strategy Challenge Fund. So that our colleagues at Innovate UK and UKRI, and of course, Innovate UK Business Connect now that David Calder is running, have been really, really, huge supporters and of course investors in a lot of the solutions that are critical. Now, I thought we would set the scene with some very interesting inspiration from abroad, because we also have to remember at the UK, we don't often look outside our four walls enough. And I think there's a lot of really interesting stuff happening, in countries around the world. We know that Japan, obviously they've been hit hardest by the aging demographic. They have, they have come and come up with very interesting policy measures, as have been countries like Singapore. So I saw a presentation about 3 weeks ago in Hong Kong, and it was my third time in China, and of course Hong Kong is slightly different. It's still kind of finding its way sort of in this new reality, but they're really trying to position themselves as sort of the gateway to Asia Pacific in terms of longevity. And so our first presentation is by someone called Professor Hidegazu Yamada, who presented a really interesting sort of concept around health as an asset. Now I know Greg Seeley will talk more about this from the ONS. We've been talking about health as an asset for a very long time, but how do we actually do it? So his presentation, with a strong, clear link to longevity and how they're seeing it, is going to present some really interesting novel ideas about how linking health as an economic asset and actually how to reward and nudge people's behavior, and how to actually realize that return on the economy and the financial sort of infrastructure and robustness of the nation. So we're going to start off with that. And then we'll enter into we'll have various sort of speakers, panelists who will each give their pitch and their perspective of how they see this very important theme. And then we'll go into a Q&A. And I obviously have some questions, but really this is about you and asking lots of questions to really stimulate an effective debate. Because in the end, we kind of know what needs to be done. It's now it is all about the action piece. So we can really, really focus on the action, how we can really work together to really drive some really important stuff, at the government level with all of our roles in businesses, entrepreneurs, scientists, it'll take the whole village to do this. And what we can really do to really start changing the system, because it needs to. It's absolutely urgent. We know this. So hopefully that will be a really good sort of way of handling the discussion today. And so I think before we start with Professor, now of course Professor Hidekawa being in Japan, and there's a crazy time-hour difference. It is a recorded presentation, but I'm sure you will really find it interesting. It's about 10 minutes long. Before we do that, we can just let David say a few words as our supporter in all this.
Sure.
Certainly, if you can hear me, that is.
David, if you could come online.
I'm online.
We can't hear you.
Oh dear. You could hear me before. It's a bit of a shame.
I can hear you, David.
You now. Very well.
Yeah. The online people can hear me, but I don't know whether you guys can.
Yes, we can.
Right.
We can.
I'm not
We
going to.
can hear you. Sorry, we're just going to put the display back on again. If you bear with us, we can hear you.
That's fine. I only want to say a few things, just to thank you all for attending, and just to let you know that it's our pleasure to have enabled this activity and this event to take place. We simply sponsored this and handed it over in many ways to Tina and Collider Health and learned colleagues elsewhere. So we were able to help organise this hybrid event. There's you present down there in London, and I think there's 58 of us online as well, just to extend that a bit. I work for Innovate UK Business Connect, which is part of the Innovate UK family. Our role is around the networking and accelerating the ability of entrepreneurial SMEs to grow and scale, but to get started on that journey by linking them to the sorts of people who can help to grant funding and other things. So we have a role in the ecosystem, and the things we do include activities such as this, where we can get behind things like Longevity Week and work with other partners who are highly capable in it and help us to deliver quality events of this type. So we've had a few technical problems. Those things happen. We're moving along now. I won't hog any more time, since we chopped a bit out, and I'll hand straight back now to Tina and to the event that's going on in London, and hopefully the people with me online will be able to hear and join in. So thank you very much, and enjoy the afternoon.
Thanks so much, David. Yes, so now what we'll do is we'll go into Professor Yamada's presentation. It's just on the slide, yeah. There we go. We can either do it on YouTube or on YouTube instead.
Good afternoon, everyone. It is a great pleasure and an honor to join you from Japan for this important session, the Health and Economic Framework for Prevention. My name is Professor Hidekazu Yamada from
But let's try that again.
Good afternoon, everyone. It is a great pleasure and an honor to join you from Japan for this important.
Sorry, we're just going to try to find the YouTube. I think this looks like YouTube.
There we go. That's it. Yeah.
Good afternoon, everyone. It is a great.
So we're going to start that again for everyone. It's the software.
Microsoft gets it
Yeah.
all.
Just so you know, for those online, we haven't got the video still, but we've heard it a couple of times, and it did appear as
Dave,
as an intro screen.
it is coming.
Okay, just so you know. Right.
Thank you, David. There we go.
Pleasure and an honor to join you from Japan for this important session, the Health and Economic Framework for Prevention. My name is Professor Hidekazu Yamada from Kindai University Anti-Aging Center in Osaka. Today, I'd like to introduce Japan's evolving framework for health as an economic asset and how we are linking epigenetic science, health data, and economic policy into one concept, health capital. The title of my talk is Health Assets and Extended Healthy Life Expectancy from Epigenome to Flourishing. From longevity to health capital. Japan is the world's most aged society. Nearly 30% of our population is now over 65 years old. This demographic transformation is not a future scenario. It is our daily reality. In Japan, the rise in life expectancy has been accompanied by an equally sharp increase in chronic disease, frailty, and healthcare expenditure. This has challenged our sustainability, but it has also created an opportunity to reimagine health as a productive force rather than a cost. In Japan, this idea did not come from theory, but from necessity. Many young people feel that health and longevity are financial burdens because a large portion of their income is automatically deducted for social security and elder care. This creates the perception that health is a cost to society. I strongly believe we must change this narrative. Health should not be seen as a cost, but as an asset, a value that grows across generations, not a debt. We are now transforming our model from sick care to health creation, from a passive welfare system to an active health capital system that rewards prevention, participation, and regeneration. If health can be measured, it can be valued. If it can be valued, it can be reinvested. This is the foundation of the health capital economy, a system where prevention creates return and resilience becomes a new form of wealth. From epigenetic clock to EpiAGR, our scientific foundation comes from the epigenetic clock, which estimates biological age from DNA methylation patterns. But chronological prediction alone cannot represent resilience or vitality. That is why we developed EpiScore and its next generation model, EpiAGR, where R stands for resilience. EpiAGR acts as a KPI framework, integrating biological, behavioral, and environmental indicators. From this data, we would like to calculate the total health asset score, ASSET THS, a kind of health stock price. Clinics in Japan and across Asia had better to applying these models in preventive medicine, tracking how exercise, nutrition, sleep, and regenerative therapies can reverse biological aging and strengthen resilience. In this analogy, EpiScore represents the fundamentals like earnings per share, while TAS represents the market valuation, how health performs in real life. EpiAGR measures the biology. TAS expresses the value. Inclusive health asset model. This model is inclusive. Health value grows through improvement, not perfection. Even individuals living with chronic conditions can increase their health asset value through measurable recovery and adaptation. In this system, recovery itself is a return on investment. Everyone can contribute to the creation of health capital. This inclusive design ensures that no one is left behind. Recognizing recovery as value creation is not only ethical, it is economically essential. Changes how we measure success, not by avoiding illness, but by regaining capacity, resilience, and meaning. Inclusive Health asset model. This model is inclusive. Health value grows through improvement, not perfection. Even individuals living with chronic conditions can increase their health asset value through measurable recovery and adaptation. In this system, recovery itself is a return on investment. Everyone can contribute to the creation of health capital. This inclusive design ensures that no one is left behind. Recognizing recovery as value creation is not only ethical, it is economically essential. It changes how we measure success, not by avoiding illness, but by regaining capacity, resilience, and meaning. Exposome and digital health capital. Health is shaped not only by genes, but by the exposome, the total lifetime exposure to environmental, social, and behavioral factors. Diet, sleep, social connection, stress, and digital behavior all influence how we age. When these exposures are integrated with biological data, they define our resilience capacity, the true engine of health capital. Digital health platforms and wearables now allow us to capture these exposures in real time. Every data point, steps walked, hours slept, emotional tone, becomes part of a dynamic record of living capital. In our framework, all layers of data, from the epigenome to the exposome, contribute to value creation. Health capital grows not only by living longer, but by living stronger, by the measurable recovery of resilience. This turns health from a static condition into a regenerative form of capital, where adaptation and recovery drive both longevity and prosperity. Total Health Asset Score, THAS. From EPIAGE-R to TAS, we now treat health as an asset class. EPIAGE-R measures biological fundamentals, the pace and quality of aging. TAS integrates biological, psychological, and social indicators, transforming health into an economic signal of human well-being. In Japan, we are now exploring how TAS can be used in real-world systems, such as health insurance incentives, corporate health programs, and national well-being indices. The goal is to align biological improvement with economic return, creating a shared value model that connects medicine, finance, and policy. Like a stock price, TAS reflects not only the current status, but also future potential. The trajectory of health capital, EPIAGE-R, provides the biological foundation. TAS expresses the total market value of health. Good afternoon, everyone. It is a great pleasure and an honor to join you from Japan for this important session, the Health and Economic Framework for Prevention. My name is Professor Hidekazu Yamada from Kindai University Anti-Aging Center in Osaka. Today, I'd like to introduce Japan's evolving framework for health.
Very, very interesting, very topical new thinking in a way that blends new thinking in longevity science, new thinking around the exposome, how we need to think about actually longevity, recognizing that social factors, environmental hazards, etc., and especially social factors actually have a huge bearing on our health, air pollution, things like that, and actually indeed on how we biologically express our health. And then, of course, the whole kind of financial links. And what occurs to me is, especially as we're entering this new phase of this new digital legislation that's going through the data use and reuse bill, there's this whole smart data economy sort of ambition. He mentioned health insurance products. There's a whole way in which we can actually view health as an asset and actually incentivize the system using all sorts of different levers. So I think and I think what's interesting about this presentation is he's pulled together those various strands of thinking in a way that makes a lot of sense in terms of where we're at with the science, where we're at with the burning platform for change, and also just new thinking. So with that, and of course we're going to probe all this in our discussion. So I'd like to invite my panelists to forward, and we'll each have their own perspective, and of course we'll have lots of questions that pick up on some of those points from Professor Litigaz's presentation. Yes, so have a seat, and I'm going to follow the order of in fact, I want this one actually. Sorry, I'll get too many seats. Now stand up now. Sorry. I'll stand up now. So essentially, we're going to go in the order. I'm going to start with Lynn Corner first. And then we'll return to Whitney for them to Magdalene. Sorry.
Hopefully everyone can hear online.
Marvelous. Okay, so I'm going to start with Greg first. Now, of course, Greg and I have been working together for a very long time with Elizabeth, who's in the audience at Context Business to Health. So your perspective and perhaps just some reflections on what you just heard.
There's an awful lot I want to talk about, so sorry, I talk a lot. I'll try to keep this in 5 minutes, but there's plenty you might also talk to me about to get a bit more detail on it. But I head up the population health monitoring area of ONS, where we specifically focus on the development and delivery of artificial intelligence. And I think starting there is important because it's very easy to see things like official statistics as quite rigid and measuring the same things the same way over time. But a very important factor of this to me is thinking, how can you make sure that our statistics remain useful to people, remain valuable, and remain relevant to a changing society, especially with the advent of various digital things,
You're trying to switch off this audio, sorry.
Okay. Hybrid meetings is on the street.
Yeah. Let's see. Try again.
Cool. How's that? So far, so good.
Yeah.
But overall, ONS has two main functions in the health space. One is our production of official stats and developing those, and one is our ad hoc research to better understand the relationships between health and the economy. Both of them are really relevant here. Two of the things I want to touch on specifically from our official stats are life expectancy and healthy life expectancy, and the health index. You can't get me to come to an event without me talking about the health index, sorry. But healthy life expectancy is particularly important because life expectancy is a very objective way of measuring how long you can expect to live. But such an important part of that is if there are points of extending life expectancy, if you don't have extensions or improvements to the quality of life that goes with it. And I think that really resonates with what we've heard Professor Limada on flourishing. If you're going to have a longer life and you're going to have that longevity alone is enough, that means quality of life as well. And so it's very exciting that these ideas have clear analogs of things that we measure already. See, yes, there is relevance here, and there are accepted ideas in our statistics which can help people make that shift from thinking about one thing to start thinking about another, such as the items here. And then, yes, the health index. Everything that I heard about the idea of health as an asset, I found really exciting because it's exactly what I've been working on for many years now. Back in 2018, the previous Chief Medical Officer, Dame Sally Davies, sadly, before Chris Whitty made being CMO a household name during the pandemic, she proposed that we should measure health in the same way we measure the economy. We should have a way of tracking it over time and really think about health as an asset for the nation and not just something that we look at statically, but really consider longitudinally what's our health like and what are we doing to protect our health as well. And the ONS Health Index, while it doesn't currently update, Tina, Elizabeth and I are working very hard to change that, and we've talked a lot with the Department of Health and Social Care to see how we can improve it and review it. But the main idea of it is to track health over time, not just, again, the idea of health being the absence of ill health, but also all of the drivers of health as well. So here we have your individual level ones, which are things like how you exercise, how you eat healthily, but also how you don't exercise, how you don't eat healthily, and things like people's propensity to get vaccinations for their children. There are lots of factors. And I think this also leads quite heavily into what Professor Yamada has described as resilience. These things we are doing to protect our future health, even if we haven't realised the health benefits by now. And then there's another element that we focus on, which is the environmental or societal elements. And what you can see is as soon as you overlay economic data or employment data with these health data by geography, there are some very clear patterns. They'll generally have worse employment outcomes, generally have worse levels of deprivation. What you don't see from that is a causal effect, and that's where, if I still have time, I'm going to very briefly talk about what our ad hoc research focuses on. And that is, we've been doing lots of work looking into the causal effect of different health interventions on labour market participation. And here we produced several papers. I can't take much credit for them because it's my colleagues more than me, but if you go on the ONS website, you can see various bulletins there and academic papers looking at how interacting with NHS talking therapies affects your probability of participating in the labour market and what your income and salary looks like after that. And then not just NHS talking therapies, but also bariatric surgery to handle overweightness, the effect of being diagnosed with endometriosis, and very recently, our most recent one, it's got lots of headline attention, thankfully, and deserves its excellent work, is just having your status as a mother, what that means for what happens next for you in the labour market. And what's excellent about this research is it's using our linked data, public health data assets, or individual level data put together during COVID when it was a necessity, and then the value of it was demonstrated to the point that we've been allowed to continue using it for research, and we have done so. But from that, we've got hospital and GP records, we've got birth and death registrations, we've got census of the spine, and you can really look at the before and after effect of these different health interventions. And you get this real observation that protecting your health improves your own individual economic outcomes, but it also improves your participation in the economy in general. And I think that's a really important message here that we see in Professor Yamada's work as well, that it's a cyclical relationship. What we've demonstrated is this causal part, that if someone has this intervention, they've got better outcomes than someone in a control group who has very equivalent situation which doesn't have an intervention. But also, yes, that means that you have better health, but then that means in turn you can move into the economy and generate the economy itself. So there's an onus on the individual to understand their health and do what they can to protect it, an onus on society to understand this and make sure that people are given the information they need to make the right decisions. But there's also a very clear benefit for businesses, or onus on businesses as well, to say, what can we do to protect our employees' health so they can participate in the market for longer and live healthily for longer? It's a benefit for everyone, is what I want to end on. Just that simple point that they're so intrinsically linked to health and the economy that there isn't a single starting point of improving your health improves the economy. It's both in turn. And the more understanding we have of this, the more research we have into this space, the better interventions we can have to ensure that people and the economy get the best outcomes.
Thanks, Greg. And there's going to be loads of questions that come from that. But I mean, I know there's very much an ambition of the current government to link health and economic growth metrics as part of the growth mission. So we'll see where that goes. And obviously, they published the NHS plan. There's certain indicators where that's certain direction of travel, which indicates that the health index will be a very useful tool. So watch this space. So I've got a few questions, and I'm sure the audience has too. So Lynn, your turn. And so we've got Lynn's slides on the presentation. So you'll just have to tell us when to move to the next slide. But so Lynn and I, as many of you know, we've been working together for a long, long time. City Longevity Initiative is a fantastic initiative which Lynn will go through. But just tapping into what Professor Mada's presentation was saying, it's very much in the context of creating environments for health and in the context of the human activism and understanding that, which is where we're kind of.
Absolutely, thanks, Tina. So just waiting for First slide. The slides to come in. Next slide, please. That's what Chris Whitty. So next time, please. So talking about in terms of the health imperative around kind of prevention, what we come at this from is that there's already 2 billion people over 60 on the planet. We're fast innovating for the next 2 billion coming through. This is absolutely urgent. And if you go to the next slide through, with Tina and with Richard in our work at the National Innovation Centre, what we've been looking at is really how we take this from debate, from rhetoric to actual reality. How do we deliver on this? Because rather depressingly, 20 years ago, I drew one of the first maps which showed a city with an 18-year difference between the poorest parts of the city, the wealthiest part of the city. You could be in Beijing, you could be in Boston, you could be in, any city across the world. And that's pretty well the same. Very, very depressingly, that is still the same. And as Tina said, in some cities, it's going the wrong way, even those cities which have got a very strong emphasis on healthy aging and looking at that. So we've got some real issues that we are very good at talking about this, but we not seem to be as good at delivering in terms of those changes through. And that's really got to be the imperative that we go to. Richard, if you could just show the next slide. With Gina, we've been working on cities. We've been looking at cities because 80% of the world's population live in urban areas. That's not to say rural areas aren't important, but this healthy life gap is where we start from in most cities. And if you go to the next slide, Richard, we also looked at this context. So report after report comes out year after year from the World Bank, from the United Nations, from local authorities, from departments of health, all basically talking about what is going to happen in terms of a policy context to address this issue. They tend to be very repetitive. We did a meta-analysis on them, and all the same themes come out time and time again. So we have got to shift this debate. Also, in every city that you come across, you will have a dementia-friendly city, an age-friendly city, a smart city, a data city, a sustainable city, a green city. These are all fundamentally looking at 2 areas. How do we have healthy people, and how do we have a healthy planet? And so how do we reduce the waste? £7 billion spent on R&D in the UK. We need to shift that from just sort of repeating, reinventing, duplicating effort to coming together and saying, how do we actually collectively address this? And this is what Tina and others have been talking about in terms of, if you look at the determinants of health, only a tiny 11% spent on healthcare. All the rest, social circumstances and individual behaviour, are where lifestyle meets cities. That's where we can really affect change. It's where we can really change lives. And so, next slide, please, Richard. This is the City of Longevity framework that with Tina and others, and we've developed in the National Innovation Centre with Richard. And it's a framework for saying, how do we actually manage this complexity? How do we take all of those determinants of health from behaviour, from brain health, through air quality, natural environment, or how do we look at the genomics, the biology of aging, the capital, the businesses? All of this is part of the healthy aging ecosystem. Incredible complexity, lots of people working in silos, but with the power of data and AI, we can start to bring it all together. And behind each tile, if you can imagine all of the evidence base that many of you in this room helped to generate, and this is a rapidly evolving kind of AI framework. And it's about an open source evidence-based set of principles and KPIs for cities, working with citizens, working with businesses, to really help to promote how we can actually understand those behavioural triggers through existing infrastructure. This is not about a new set of infrastructure. It's using what's already there, but really through those day-to-day touch points, really help to nudge those healthier behaviours. If we just look at one of the final slides, next slide, you can see that complexity in terms of what we have to kind of pull together here in terms of social circumstances, the built environment, the medical care, different technologies and economies. But through all of this, we can start to reimagine what we need to do to actually ensure that people have happier, healthier, longer lives. And as Tina said, part of this is actually working with citizens and to completely accept that many of our policies, many of our approaches are simply not working. So we need to completely, quite radically reimagine them. An example in terms of education is that in the UK, 80% of the education budget is spent on the under 25s. That's ludicrous in the context of a 100-year life when people need to reskill and work across many, many years. So that whole kind of mindset we need to radically shift. Final slide, Richard. If you just click at the bottom. And this just shows the City of Longevity framework in action. We picked to show that the determinants of healthy aging and healthier, happier, longer lives, we need residents at the start. You can imagine policymakers putting it together, knowing that we need to look at physical activity, social inclusion, loneliness kills. We need to look at how we can understand the cultural capital of a city, the nighttime economy, perhaps. We look at how that can be personalized. We look at sort of areas such as dancing. You don't have to go to a gym to be healthy. What do people love to do to connect? All of those factors that influence healthy longevity, influence healthier, better lives, can come together for policymakers to really reimagine how we can actually take citizens' preferences and behaviours and really start to kind of build healthier, happier, longer lives. But basically, with that data approach, not wasting any of the existing evidence, and fundamentally working with residents, working with citizens, working with businesses to bring forward that change. And I think it's open source. It's intended to be where all of us co-create it effectively. But that data at the heart of it is going to be really so important, so that, as we said in the start, we can take health as an asset, but we can shift this from being a rhetoric to actually reimagining how we actually might deliver it, so that we're not sitting here in another 5 years' time with that healthy life expectancy gap being the same in many, many cities. And so that's just kind of our take on how we can really put residents at the centre of this, really put businesses at the centre of it, and understand that health is not hospital or a physician. It's basically all our behaviours, it's our industry, it's our entertainment, it's our leisure, and at the heart of it is people coming together, social connection, and making sure that we can enjoy those happier, healthier, longer lives.
Thanks, Lynn. It's worth mentioning that, of course, and in Nick, also to on this as well. I mean, we really have been looking abroad and looking at different cities around the world, which are obviously very, very different. And I don't know how many cities at the moment you're working with. What's the rough tally? 20. Yeah. So I was, funnily enough, because I was in Riyadh last week, and what really came out strong. Now there, yes, the Middle East has been infected by the Western disease sort of scourge. But what they've also realized, taking in the solutions from the West are also not necessarily the right answer either, because it's a completely different culture. So the whole kind of citizen engagement perspective is absolutely, they've really realized that has to be there. It's just not going to work otherwise. So it's fascinating. Well, listen, we're going to go to Whitney now, who's online. Now, the International World Building Institute is an organization that both Elizabeth and I, my colleague at this house, have been working with for some time. And of course, they are a very, very good example of how we really need to see the built environment and the place where we live as a huge engine for health. And actually, there's an enormous amount of really interesting health economic data that's coming out, working with groups like this who are, advising buildings and neighborhoods, et cetera, how they actually need to be built to promote health. And this is everything from clean air to light to all those sorts of things, which are massively impact our biology and have to be figured into this whole longevity debate. So Whitney, she's based in the States. She works with our colleagues in Europe, with Sarah and Marie. And she's going to present some really interesting data on the whole health economics of this from their perspective. And of course, they work internationally as well, so we'll have a huge international perspective. So Whitney, we're going to bring you on. We've got your slides, so you just have to tell us when to switch to your next slide.
Wonderful. Well, can everyone hear me in the room, and everyone in my virtual community hear me as well? Oh, there's a virtual thumbs up. I love that. All right, you're in the ether. Fantastic. In the room?
Yep, we can hear you.
All right, we're live then. Fantastic. I am ready for my slides. So, hi everyone. Whitney Austin Gray. I do research at the International Well Building Institute. My background, my PhD, my training all comes from public health. But I found myself very frustrated in public health. We often are trying to solve these problems where we feel like there are solutions, but too often those solutions are not being used. So I was always taught, and I teach my students today, that when it comes to public health, we either legislate out the problem, we educate out the problem, or we design out the problem. And I was really shocked to find how little partnership was active from the design and real estate community within public health. And what's interesting is when you look at the history of cities, we actually have an incredible history that we share together. In the States, we really look at the city beautification or city beautiful movement. Olmsted was very famous for looking at Central Park, which was considered the lungs of the city when we had rampant disease spreading. And there's so many other examples. Olmsted went on to become a leader in the Sanitary Commission. And I put that forward because he's a landscape architect, and public health and landscape architecture design work to understand that cities could make you healthy or make you very sick. We've lost our way. Often it's attributed in the 60s and 70s to looking at fast-acting pharmaceuticals, tech, and this idea that individuals were the focus and not the places we spend time. So I'm very excited that after many years to work with International Well Building Institute on the well building standard. This is an above code standard. There are not global standards right now, for example, on indoor air quality. And you might be interested to know that that comes up as a second or third, it kind of varies, leading cause of death in the world that's absolutely preventable. Many people don't realize also the extremely strong link that we're looking at around air quality, particulate matter, and issues of dementia, depression, anxiety, even suicide. So there are so many powerful ways that we can change the environment to help people live longer and better. So the next slide is something I often ask my audiences around the world is how much would an additional 10 years of life be worth to you? And I think this room is a pretty warm room. I think many people here have thought about this question, but I work with real estate. And real estate is the largest asset class in the world. I cannot assume that anyone in real estate has had any training in health. Yet they will shape and dictate where we spend 90% of our lives. So typically I use the stat of 50 years, which means about 45 have been spent indoors. For this audience, we're trying to get everyone at least to 100. So we'll say 90 years. So I just want you to think about the fact that when you look at all the determinants of health, is that your environment will dictate the majority of your behaviors, and you spend the majority of your life indoors in environments that people have designed that have no formal training in health, none. Now, these individuals might have chosen professionally to take on accreditation like the WELL AP. They might, and they will, and are required to respond to building code. You might be interested to know that building code was informed by fire safety and still is. It's not innovated to look at how we can breathe better, what the water quality will be at the highest level to give us access to it, or the lighting quality that allows us to deal with cataracts and engage people to work longer and better. And that's just the beginning. The places we spend time in also reduce isolation. They create community. We think about 85% of what you eat will come from about 5 miles. Sorry, I don't have the kilometers right there off the top of my head around where you live, the radius. In other words, you eat what's close and what's convenient. So we have ways to make you live longer when you think about the environments that you spend time in today, not tomorrow. So the next slide just highlights that as we live longer, and about 20 years longer than we did, for example, in 1962, is that people are rethinking the first and the second part of their retirement. They will work maybe 40 years, if not 50. The next generation might work even longer, even though our parents might have only worked 30 years. So should you work all 30 straight? There's a large conversation right now that maybe you shouldn't. Maybe there should be multiple breaks when we think about longevity. But 90% of your time is spent indoors, 90,000 hours is spent at work. Your highest exposure is going to be in the environments you spend time in that are not regulated, hence the need for an above code standard. So in the next slide, we look at this concept that your lifespan is longer than your brain span. Next slide. And so we're trying to understand how can we better invest in health and how can that pay back? And when I talk again to audiences that this is a very new concept, I really break down what is health. And for many of my real estate advisors, they're looking at dollars and cents of how will this benefit my people? And if they're healthy 20 years from now, that doesn't benefit me for them to work better today. So we look at the economic argument. This is so imperative. In public health, we get a little too comfortable telling people what they should do. And I don't think we get active enough in changing the environments to make the easy choice the healthy choice. And so we're left telling people what they should do, yet not creating environments that enable people to do what they can for health. And so often we find that if people have to choose health that's hard, they don't. But if we provide healthy food and we provide access to their colleagues and we provide spaces for interaction and we provide healthy water and great light and we enable people to move throughout the day and we look at thermal comfort and menopause and we look at all these different ways that we can provide better spaces, it turns out that we can create an asset for the country, which is our people. Next slide. So this is a quote from Warren Buffett, one of the most famous investors of all time. And I really love it because I work in the building trades, in the built environment. And his quote is that someone is sitting in the shade today because someone planted a tree a long time ago. For me, these are the people that built the buildings, like the great work that we're doing in Huddersfield, which I think we'll speak about more around WELL certification, that demonstrate that they're going to be there for at least 50 more years, if not longer. That's the life of a building. And we have a huge impact that we can make by planting the trees and those healthy buildings today. So next slide. I think everyone can agree that when we're looking, next slide, health is that it's an investment and not an expense, but we do need to prove that on our balance sheets for a lot of the private industry that's moving rapidly. So I think I will give back the stage. The rest of my slides, maybe if you want to just bop through them so people can take a look. For all my researchers in the audience, this is the reports, the evidence, the peer-reviewed journals, and you keep going through, that demonstrate that investing in health pays back and that the WELL certification as an intervention can demonstrate that if you pursue this, particularly at these platinum gold levels, that we can document that people report being happier, healthier, more productive, more engaged. Next slide. This actually even outperformed green buildings. We know this can drive rents. We know this can drive premiums. Those are powerful words in my industry, right? Health becomes the benefit, but these rental premiums become the driver. Next slide. So if you'd like to learn more about the WELL Building Standard, next slide, you're welcome to download some of our reports that look at the movement that we're taking in Europe. So what's exciting is that we're in about 140 countries around the world. With that, we have an incredible comparison of the cities, the buildings that are outperforming others based on the 10 concepts of air, water, nourishment, light, movement, thermal comfort, sound, materials, mind, and community. I will also say that we are huge partners. We do not want to recreate the wheel. We don't want to have a client here that a client has 10 different programs they're involved in. We want to always synchronize that. And so our design teams also want to integrate. So if there is a plan, a program, a KPI that you are tracking with a large company, we want to be involved to look at how the real estate will support that. Next slide. So we can just jot to the end here. And if folks are interested, I have a QR code. Next slide on the Health Pays Back report. So if you'd like to learn more about what we're doing with WELL and what we're doing with measuring the impact of WELL on human health and well-being globally, please download the report. And furthermore, if you'd like to specifically include a case study, we would invite you to do so. Next slide. I think that's the website I have for you. And then that's actually my QR code. So for all my virtual friends and colleagues online, do give me a shout out. I always love to connect in this space. And my two colleagues that are located in the UK were not available today to join. So I know that I'm only a virtual presence. I wish I was there in person, but hopefully I represented my virtual community. So please reach out and look forward to further questions. Thanks so much for having us.
Thanks so much, Whitney. That was great. And thank you for dialing in from the States. One thing before I hand over to Magdalena, what really fascinates me about the work of what Whitney was presented is the sheer, and I'm hearing this a lot from my travels, the longevity circles. There's more and more interest from real estate, commercial real estate, property developers, all wanting to bring longevity into their frame and being able to measure health benefits of healthy buildings. Obviously, there's a huge investment case behind that. So I'm predicting, and already we're seeing a lot more investment monies under the longevity banner in that space, which is fascinating. In fact, Global Wellness Institute are just hosting a big event next week in Dubai about all this. I went to their session in New York about all this. So it really is, catching on. And of course, that links in very, very nicely with the exosome. And of course, we're seeing a lot of very interesting research, really looking at the impact of urban interventions, access to green spaces, air quality, noise pollution is a big thing, and how, through simple changes in policy, they can measure in real time the impacts on human health in populations and even at an individual level, because of everyone's wearing, the sensor technologies and all this sort of, the obvious sort of ways in which to measure what is actually impacting them on the inside, measurement of biomarkers, etc. So this is actually the whole new frontier of longevity that I think is really starting to resonate, because we can actually see data-driven impact, which can influence policy and investment decisions. So I think it's fascinating. And of course, that's my segue to Magdalena, who we've only connected quite recently, but what the work that you're doing is obviously just hot off the press. You're going to tell us. But what is fascinating to me is about how you're harnessing live private sector data to give very accurate pictures of financial well-being, which of course links to health. So I'm going to hand over to you and tell us what you're launching and why it's really relevant to today's discussion.
Thank you so much. Yeah, it's really good. So I'm bringing back the kind of data aspect. So I'm from Farm Data Company, which is a non-for-profit based at the University of Edinburgh. And as I was just saying, what we do is we provide access to near real-time economic data, socioeconomic data, from private sector, and primarily banking data. So we do see the identified income and expenditure of about 10% of the population. It's quite significant. And obviously, we know that financial pressures really affect your health, both mental and physical health. And on the other hand, people who are unwell or ill health, they struggle to stay work or provide for their family. So that creates even more pressures. So we are in that space of looking at the bi-directional relationship between health and wealth and financial well-being. So the data we provide access to, so we are in the space of very much looking at how we can improve economic well-being in the UK, how can we reduce poverty, how can we reduce inequalities. And we do it through three ways. So one way is that we become sort of space broker. So we get the data donated to us and we provide access to this data at the individual level. The viewer researcher, similar to us, if you're a researcher, we run a trust-based environment, you can access this de-identified granular data that tells you about people's income and expenditure. So it's quite holistic. So you can actually see, how much people are spending on energy, on childcare, how much are they saving, and so forth. So it gives you a very good picture. It's obviously de-identified, you can only access it in the trusted environment. You need to go through a variety of approvals and so forth. On the other hand, we also continuously work with private sector, so we try to bring more and more this private sector data. This is part of the wider movement in the UK and in Europe. So this is called Smart Data Research UK. If you haven't heard of it, it's a UKRI program. So we're funded by UKRI, ESRC, which is the Economic and Social Research Council. And essentially, so there's 7 data services. So we are one of them, focusing on socioeconomic data. And then the other thing is we also aggregate this data to data zone and then to intermediate or MSO level, and also to the regional and national level. And then we create indicators. So because our space is the economic well-being, the indicators at the moment is we're looking at people with overdraft, we're looking at people who are living beyond their means, so they're spending more than their income, and they have low emergency resilience. So people who, for example, within a month, with over 5 weeks, they have 2 or more instances that their income is, that the balance is below 100 pounds. So, for example, if you're hit with something breaks down, your car breaks down, washing machine, you know, what you do, it puts you a little bit, you have more strain. So we have, so this is kind of like, today actually we launched a tool called Economic Wellbeing Explorer, which is available to everyone.
We'll make sure we circulate the link out.
We'll do, yeah. And essentially, yeah, you can. It's really quite a start. You can see the regional inequalities. You can really then filter by age, by income groups. So you can have a look and play with it. We do work with local authorities who are starting to use the tool, but also with other NGOs as well. And this is to give them. So this data, because it's near real time, that's why it's so powerful. So we get data weekly, which means you can see what's happening with the economy, in the society, at a really, really good time. However, this data is to complement the official statistics. We are never saying do not use anything else to statistics. Absolutely not, because there are biases, obviously, and constraints with data. So obviously, it's a bank data. It's never going to be fully representative. If you don't have a bank account, you're not going to be in the same one. So there's constraints. So we have to be very honest, very transparent. It's never going to be as representative as an data, but obviously you have calling the response rate, the survey. So this is very much how we can complement. We've got projects on a variety of things. In terms of our research, so we do work a lot with medical school, and we have projects looking, for example, the impact of housing on respiratory disease, and this is the research is linking our data and looking at child health data and housing with air pollution. So everything that's been mentioned, kind of very holistic view. We have projects looking at the economic activity in COVID, so the impact of COVID on economic activity. It's a variety of things in this space. We're also looking at gambling, obviously, as well. So a variety of bunch of research projects, as well as the kind of economic wellbeing explorer, which we will circulate the link. It's really great for you to have. Just really quite an eye-opener, really.
So I had, so this is only a few days ago that Magdalene and I sort of spoke, but I had a look at the dashboard and it was really, very, very interesting. And I think we know that the future is all about real time. We need more of real time data, and we need to connect up data sets. We know that that's the part of the future.
Yeah.
And we talked a lot about how you connect up. And one of my questions actually was, I know you're doing a lot with the banks, but of course you're moving into other verticals as well. And, and connecting that, obviously, in terms of longitudinal sort of analyses across people's lifetimes, that would be super, super useful.
Yeah.
I mean, that's Exposome, talking. Because really what you want to do is to track, what exposures and what life circumstances, like, losing a job or whatever, how that really hits your health. And that is the ambition of the Human Exposome Project, which I'm very, very involved in, is to be able to capture that data at an individual level and see what the impact is on health trajectories, because then you can really meaningfully go back and work out, what are the policy interventions at scale that will really have an impact.
Yeah.
And we already know, and this is, I didn't realize this until I actually went into it, just the stuff that Whitney was talking about. You mentioned, air quality. Air quality is such a significant driver of poor health, and of course the Congress as well, and of course social situations. We're realizing absolutely this is becoming an even bigger and bigger part of the story, and impacts our biology. So this is the sort of stuff that needs to enter into the longevity debate. This is the stuff that is really affecting people, that you're not going to find in animal studies.
So that study actually is really interesting, because it's part of looking at the impact of housing. The researchers are still looking at this in the context of net zero measures and retrofitting, because obviously there's a push to make them want support. But the hypothesis is that some of the retrofitting measures can actually make your health worse, because they are tracking their points, depending on the installation.
Of course,
It's really, it's complex.
Absolutely. So this is fascinating. So we've got some really interesting perspectives, which I hope will widen the debate on what longevity is. Because I think longevity is way, way beyond the biology of aging. It's absolutely about our environments. Human Exposome Project is all about that. If anyone wants to find out more about that, speak to me afterwards. I'm very involved in that. Speaking to areas around the world. In fact, Lynn and I were just in the island of Jersey, which is a very interesting test case. They want to become the island of longevity, but they're seeing it through the lens of the exosome and how they can impact the residents at scale, very socioeconomically diverse. They want to be a hub for exosome research. Very, very interesting context for a tester. So we're going to start opening and have some really interesting questions, I hope. And Richard, if I can leave you to monitor the Q&A online. I've obviously got a few questions, and I'll just kick off, but I'm sure the audience will also have some questions about onto David in a second. So what strikes, I'm just going to go around, the panel, hearing what you have heard, what strikes you in terms of even how you will be thinking differently about longevity, what we need to do, thinking health, economic growth? I'll go to you first, then, just because you're sitting next to me.
I think one of the first things is that we collectively know so much, so I'm actually quite optimistic that we have so much knowledge, from kind of everything from kind of sustainability in terms of, as you said, about noise pollution, air pollution, etc. And so I'm very optimistic when we bring all that together. I'm very struck from journeys around kind of the world. I've just come back from Beijing with Jean and also Jersey, which is a little closer. But the places that are really succeeding are the ones that have both long-term policy and connected policy. Whereas I think, we said earlier that the investing now in 2025 will pay dividends in a China that's 2025 will pay dividends in 2075. And you have to have that long-term joined-up policy and accept that the actual real benefit, the dividend, if you like, is not necessarily in your budget. So short-term thinking has just got to go, and I think that's where we have a massive political opportunity to kind of argue for that as well. So there are 2 points that I think that really, really resonate, is that long-term view on this, and that kind of almost leaving the ego at the door, that actually this is not all about our project or our political cycle. Actually, this is humanity. This has got to be lived.
Yeah, and we know that short-termism is the challenge in governance and policy making. It's by definition, it is short-term because of political cycles, which is really, really hard to break. Great. To you.
I'm getting really bored off. So I think basically the same thing. There's a lot of information out there around how we draw it together. That really helps make this holistic case, especially where everything Magdalena was just saying about her data. I wasn't thinking about it as any sort of substitute for ONS, don't worry, but I was thinking in our public health data assets, I'm quite greedy. I'm just thinking, I'm always thinking, what can we add to that and learn more? And I feel like that insight into people's spending and people's savings adds so much dimension to the story of what some of these interventions mean, what people's health before and after intervention means, what people's economic position before and afterwards means, not just how much they're earning, but actually what they have in savings and all those numbers we're looking at. There's a whole new area of that research that we can understand better. And I think that that's just something which, the more we look at all of the different evidence we have in lots of places, if we want people to think about this holistically, we need to have a way of drawing it together and quantifying it in some way, whether it's an index, whether it's something with a currency sign attached to it, which is generally what makes politicians pay more attention to it. But again, it needs to be a longer term thing, because we're not going to make improvements to something like healthy life expectancy or something measurable in resilience or flourishing in the short term. You may see some of the improvements start, but you need people who are committed to making these as longer term investments.
So I'm going to just, before we go to Magdalena, can we bring Whitney on Richard, to see if she's happy to?
There's also a question online.
Okay.
That we can.
So we can go to Whitney and then we'll move on to questions.
And then, can you just repeat the question? We're not able to hear everything.
Oh, sorry, Whitney. So I was just going to just give everyone on the panel a chance to kind of comment on, having heard what we've just been talking about, what's really strikes you that perhaps hadn't struck you before, or what you think the real opportunity is or the real challenge in terms of really cracking this nut. How can we actually really jump, to where we need to, linking health and economic, growth together and really crack this prevention nut?
I think the biggest thing I would add in there is that given the high risk of isolation while aging, place is so critical and often an afterthought. We think that if we have the behavior and the prescriptions and the plan, that it works. But again and again, we see wellness real estate or senior living that works, and then ones that fail. And those aren't concepts to wait for when you're 70. They're concepts that we have to build in every day. So the idea of brain capital, social capital, this idea that we know that the longest living people not only are connected through relationships and purpose, but that we're really tied to being part of community. And I think that there's not enough conversation from the people that build community from the public health perspective to engage them. And I don't think that, I'll be very honest here, I think that I sit in a lot of rooms with a lot of researchers, and we get really comfortable telling people what they need to do, but we don't always roll up our sleeves and spend the hard time looking at the budget and the balance sheets that a lot of these companies have to deal with every day to make the hard investment to create those places for health. I think it's humbling. I think we need more warriors out there speaking to those developers in real estate. And those also are voters. So from a political perspective, infrastructure development is a big thing on the agenda. And so when we look at college universities, we look at the development of infrastructure. I mentioned Huddersfield and the great work that they're doing as an example in the UK, and there's so many more others. I really think that we should all be humble enough to be able to speak across disciplines and welcome, new members in that are looking at different balance sheets around longevity and how they're making those equations work. And I think that because we're problem solvers, we have an opportunity to really guide that conversation and be the leader. And I think the other thing that I would just mention is for WELL is that we're global in scope. So with 140 countries under our belt, it becomes very interesting where we know that there's a health intervention and yet we see it pursued or we fail to see it pursued. And what are those cultural barriers? Is something that I would love to share more with this group around, how do you unite groups successfully? How do you fail to do that? How do you create safe places? How do you get people to stay in those places and build community? So a lot of lessons learned from global perspective. Thank you, Tina, for incorporating that global perspective today.
Thanks so much, Whitney, and all your points are hugely well made and absolutely bang on. So couldn't agree with you more. And Lynn wants to say something. Yeah.
I just could agree on. I think that's one of the areas that we've all covered is around all the evidence of that. So, for example, we see from study after study, 20 years of evidence that social connection is the issue in terms of healthy aging, longevity, happiness, etc. And so, that human connection, that sense of belonging, that sense of being part of the place. I know Judith Phillips, the ESRC and the ESRC at the UK have done a huge amount on that. But that matters. And yet, at the same time, you read that most pubs are shutting down. You see nightclubs now, places where people come together for joyful dancing and kind of the nighttime economy. They're shutting at the rate of, I think the statistic is if they are continuing to shut at the same rate, there will be not left in 7 years or something. What that tells you is that, we're not connecting in the same way, whether or not this is a post-pandemic, this is the cost of living in terms of how much housing costs, the sheer cost of living, the increase in that. So our cities and our places, the areas that we have lent on in order to come together to kind of find people of mutual interest, the joy of dancing, which you could talk about far more than me. We're losing that. We mustn't just see this as just kind of infrastructure and buildings and systems and policy. It is at the heart of it about people and where we come together to have fun and how we can really kind of address that. I'm one of the largest citizen networks globally. So we have around about 20 countries, citizens where we're polling, surveying on healthy aging. It really resonates what Whitney has just said there in terms of when you actually break this down. Again, we've got to take it out of the policy rhetoric and the research rhetoric, because for those people on the poorer side of that community, you're looking at people working 3 jobs, constantly living with debt stress, relationship stress, 24/7, of the attrition of that kind of absolute noise of really not being able to cope and on the edge. And that cumulative stress, we know, is a longevity issue. So that's that people side. But even when we poll the very wealthy, the people in the other end of the spectrum, we've got an enormous noise of wearables, data. I must do this. I'm worried that I haven't done this. What does this mean? And so as from a citizen point of view, we're not translating this evidence very, very effectively either. And I think, we've got to get much better at kind of pulling together to, as Whitney's saying, to kind of make sure that this knowledge, this information at a personal level is understandable and accessible and affordable. Because, again, the ultimate dial shift is from citizens understanding this and understanding choices and what we can do differently to realise that longer run.
Fantastic, and good segue from Magdalena. Final comment, and then we'll open up for questions.
I think what I can add is, I guess, to me is, I think it's really important to not forget, even events like this or public engagement events, or you can talk to people and actually raise the awareness as well. But to me, being on the data side, I think it's all about making more of that evidence to actually becomes action, and it's what you're saying as well. So future data also needs to be part of the solution, and working together and put that ego on the side itself, but also access to health and social care. We know that actually those can be done the most, but actually that was a barrier. So there's lots to be done, lots of things to be covered, and not just for those up to involve.
Thanks, Magdalena. We'll have one question online, and then I know there's a couple here in the audience that want to. By the way, just so you know, the room, we do actually have the room beyond 4 o'clock. I will take the discussion, break a little bit into our networking time, because I know we started late, but if we carry on for at least 10 more minutes or so, and we do actually have the room, depending on what's the chat afterwards as well. But let's have here something on that.
Great. So the first question's from Mark Benning. Can one of the panelists discuss the effectiveness of social prescribing in the health asset stream?
Great question, Mark. I mean, social prescribing, obviously, when areas such as kind of walking or access to culture, arts, etc., is prescribed as a health intervention, effectively. Very started in the UK, Canada, and Singapore. Others have also, adopted that kind of model. I think it's important. I think it has its place, but I think it doesn't have scale necessarily. And so I think for social prescribing, we need, again, a bit of a radical reimagination of how we involve citizens kind of in that debate, and don't necessarily rely on that as a one size fits all, if you like. I mean, I think one of the issues in this is that we, as I say, have a very Western model, and we try and kind of roll it out across other places. But the scale of the challenge here is something that we've got to radically rethink, because we simply haven't got the resources to invest in that model, across multiple systems.
I mean, what I would say is that in theory, it's a wonderful tool, but I think it's almost too late sometimes. And I think that's part of our problem. We always start these things too late, knowing what's best for us. But actually, so really the objective needs to be to try and intervene far earlier with all the things that we know will really deliver on massive health impacts. Things like apps between spaces, movement, all those sorts of things, which are critical here. I'm going to go round, and I'm going to go to David first, because I saw you first, and then we've got so David, you first, and then I know Alan's got one, and then so we've got these four. David.
So my question is for Greg. I think I don't think I understand enough about the health index you spoke about. And likewise, I didn't understand enough about the total health asset score that Professor Yamada talked about. Because in each case, you were saying this would be a great thing, but it's not clear to me do we have it. Are we anywhere close to a situation where there's a single meaningful metric rather than 101 different metrics that people can shrug up? But if there's a single metric that's read out on the news at 10, hey, now we have these are unemployment figures, we have this inflation rate, and by the way, the health index has gone down. And we'll have the panelists saying, why has it gone down? How close are we to having that?
We are a negative distance in that, because we had it, as everyone started.
So we're trying to get it back.
We produced our prototype at the end of 2020, covering years 2015 to 2018. And this was precisely to describe it as a single number score. But all of the scores which put it together were underneath this as well and visible to users. And this was something that we thought was very important, because let's be real, people understand health better than they understand finance, so it's more personally important to them. You won't necessarily expect to understand how GDP is constructed, but if I tell you the score for health is this, then people are going to think, well, that's not my expectation of health. Everyone has a lived experience of health, and that's how close they are to financial systems. And so we designed the health index with 3 core supplements of healthy people, which were your health outcomes, things like prevalence of conditions, mortality, healthy lives, which were your individual circumstances, and healthy places, which were the environmental and societal ones. And all of those had scores which could be tracked over time, and you could see what how health was changing between different topics, how health was changing between different geographical areas over the course of this existence. Speaking a bit frankly, it was a little bit of hubris. That's why we don't have the health index now. There was a lot of confidence in it in ONS at a point where we were making some difficult decisions about what we would prioritise, and there was some sadly misplaced confidence about how easily we could get this externally funded so we could continue the work, and then that didn't happen. So now for the past few years we've been campaigning to say, how can we bring this back while also acting upon some of the areas it could improve? Because yes, it was a simple score, it was something people were starting to accept. It had a lot of traction in local authorities, for example, for their public health monitoring, but we hadn't yet broken into mass use in central government. We hadn't got that much attention in national journalism. That's something that's really exciting in itself for such a statistic in its infancy. So now we're thinking, how can we make it more timely? How can we incorporate more innovative data sources so it's not relying on official statistics, which are great but slow, so we can understand more. And then
You're saying it's lacking funding. So how much funding was missing to make this a reality?
I think our last estimate was something like 2 million would get us to resume development, make the innovation improvements that we thought were most important, and start to produce them regularly again over the course of 3 years. And then less than that.
It's a tiny drop in the bucket. And of course,
What
this
an
is
insane country we're in.
and of course, Business for Health are very involved in this whole process because of access to more private sector data, which of course is what management do. So we knew that we need better data feeds, especially in the private sector of the business world. But I mean, these are all what we had in our plans.
Yes, exactly.
So yes, it is a drop in the bucket compared to what it could actually generate in terms of return.
Certainly.
But again, it's the long term thinking and connecting with all the dots internally and down that road, which is so.
So that short term impact, it's just put in 3 months and then 3 months afterwards, people already discussing, oh, it's changed. Why is this changed?
Well, watch this space. But yes. Alan.
Thank you. First of all, really insightful. I mean, I really feel that I've learned something today that I didn't know. And being the arrogant son of a bitch that people know me to be, that's really helpful. So thank you for that.
I feel really flattered.
No, but the point I make is this, is that I think we're looking at it the wrong way around. We're still looking at it top down, bottom up. Let me try and explain what I mean by that. Is that today in education, you can deliver a personal learning journey and a personal learning outcome through an AI chatbot. Easily. That is perfectly functional, and people I know have delivered that in a scale. What is really interesting is that chatbot can also understand the competency level of the individual student. If you follow that theory through, you've just constructed education where you can teach each individual student individually to their own capability and competency. I would argue what I've learned today, particularly from Lynn and from Greg, is that you're sitting on the database and the methodology to deliver a bottom-up solution that can cost-effectively be put in people's hands for them to use. Then I come back to the community piece, and I'm saying to you, if you build it bottom-up, effectively peer-to-peer education comes into place. Getting a doctor's appointment today, getting any analysis of any medical problem is almost an insurmountable problem. And we're relying on governments to solve this problem, or philanthropic organizations. I think what you have created and what Tina is advocating can be delivered now extremely efficiently and extremely cost effectively, and I know people can deliver that. But your comments, please. Am I completely bonkers, or does that make some sense?
It makes absolute sense. And it's actually built into the plan for City of Longevity that we put residents first and foremost, and we understand kind of that walk, if you like, in terms of how almost we do need the policy frameworks, of course, but what we actually need is residents to understand and to deliver that information directly to them. The other area that you've raised, which is really, really important, is trust. And we have a partnership with Edelman, who are kind of the world's expert, if you like, one of the world's largest PR comms agencies, expert on trust. And that issue that you raise about the low trust in institutions, in business, is at an all-time high.
And that's interruption.
And yes, you can. But I'm just saying, in terms of trust in peers, we know that's very, very high. And so how we could actually leverage that is going to be.
So can I share with the world how to solve that problem? Let me just give you just a piece of philosophy. I believe that AI today is about built for purpose and mission driven. I think it's about authentic content, and we've delivered that. And it's about what I would describe as a trust coefficient. I was fortunate enough to discover recently a blockchain that is being built out of San Francisco called Bitensor. Bitensor is not about crypto or other factors. It's about knowledge and insights. Effectively, it's about the validation of innovation, which cannot be corrupted. Some very serious people and some very serious money behind this. But what they're missing is the bit that you guys have got. In other words, they've developed the trust coefficient. They just don't know how to deploy it. Conversation with one of the leading funders only 2 weeks ago, and they're looking for exemplars to actually deliver the solution. So the problem with AI has always been trust and authenticity. Effectively, there's a solution for that, which I'm very happy to share with you.
That sounds great. We'd be delighted to do that. And again, it speaks to that partnership and that about that no one organisation, no one country has got all of this knowledge, but how can we kind of collaborate smartly, cross boundaries, cross sector, cross discipline?
When the government puts 3 million into AI innovation, and that's not even, I mean, it's nonsense. But effectively, there is something here generically from what we've been listening to today. And I think all the sites have been really useful. Tina, can I ask you, will you share these presentations? Are they available?
Yeah, we're going to actually share the recording after the event to everyone who registered. So, yeah, thanks. We'll cut out the mumbling bit at the beginning. That's trying to figure out the technology if we can. Yeah. So, just a couple more questions.
Yeah. Before,
yes.
Both made up again. Science inputs there certainly new technology, healthcare businesses, one of which has become the one that makes it very like I'm saying that. Along with what we're talking about, the business experience. When it comes to the work state of the UK, where we are number 22 hours, federal higher from this, actually, the US is the worst, we're two worse in terms of health. And in both cases, the US is a mess. The NHS is the problem. And I don't mean that from a personal point of view, from the structures and other things, the 700 pound of an England, 55 million people, single system, and so it's done. That's the thing, the most time. How do we organ? And they, one of the terms that
so your question is, how do we actually? What's your question?
How do we get out there system delivering, which you can see better ones out there that are the freedom to take risk. This is risk averse.
So I think the risk element is a critical.
And it's made it's a terrible situation. So when people go on these members, we're not doing this in terms of the healthy life year expectancies among social economic groups. But the solution is to cut it out in different other things to have systems of the graphic on it. Because we have one price fits all drive, we have a London, which have no idea it's the topic of system. And it's understand that's what's happening.
Well, we have the 10-year plan, which is attempting to answer some of those questions.
Well,
I don't know what everyone feels. I mean, in terms of moving, outside the community, analog to digital, et cetera, et cetera. That is an attempt to try and, well,
problems with happening. UK, there are others, and the US is not an example of the two individuals in relationship. A small group live very highly concentrated in the larger group. So it's how do we change those things of delivering systems outside and the whole my mind isn't being the best. You actually read all these things, I told these things, and Jeremy took coverage of it very well. We don't even try to sell it to people into the right way because we know that it'll be slow to adapt.
So this is a massive question, as we know, which we're not going to solve in today's discussion. I personally see it as very much I think system is critical here. And we talk a lot about system change, the structure. I mean, for me, it comes down to the incentives of how we measure the system and looking at it right. It's the incentive structures. I don't know if anyone else wants to comment, but this is where the evidence base to change, and this is where the economic argument is so powerful, which we must lever, because frankly, I think that's the only way we're going to change the system is the economic argument. Got the burning platform.
Just the point that Carol's going on. If it is going to work, then it's going to be devolution of control of the funding and the approaches. At the moment, there's a lot of record, but the reality of control sits in one organization, not the neighboring. It's needed. And this applies to some other different countries. Wherever is that nature of structure, risk requires the ability to take risk in the funding community.
Any other comments before we take? You've got a question. Any other comments on the NHS? We know it's a difficult one.
It is a difficult one, but I think the point you make is a really good one, that we've got to get better at understanding the incentives and the business models, because unless we understand that, we're not going to be able to affect change, and we're not going to be able to shift it from the vast majority spent on fixing, treating preventable conditions.
So this is where the whole health and economic growth linkage is so key to this, because it's the only way I think we're going to be able to change anything. You had a question.
Yeah, completely agree. And I work in mostly with workplaces in women's health. And predominantly in brain health, so understanding what can we do to kind of move the needle on the cognitive health issues that we've got across women's health in particular. The latest statistics showed 83% of women hitting perimenopause experiencing brain fog. Brain fog's not a mental health issue, it's a cognitive health issue, but most organisations don't even understand what cognitive health issue is. They're measuring for mental health, but they're not measuring for cognitive health. They're not looking at broader brain health. And you did that brilliant piece then 17 years ago about mental capital and what we can do that right across the lifespan that impacts on this, including on the workplace. And the implementation science says it takes 17 years to get research into practice. Even then, it's only 14% of research into practice. This morning, I was showing it at an event for women in sport, and demonstrating how impactful that all is. I suppose my question is, how can we? Workplaces are a good place to start, because the NHS is obviously overwhelmed. Workplaces have that have a real need for staff that are engaged. Only 10% of staff are engaged, and they need staff that are functioning well. 48% of staff that are experiencing burnout. So we've got their ear, they're interested, but to fund it, we've got to demonstrate that benefit, and stop them trying to fund it from tiny weeny wellbeing budgets and fund it from investment budgets. How do we? Any ideas? Greatly received.
Well, this is the heart of some of the work that Elizabeth and I have been doing, obviously in the context of Business for Health. And of course, there is a huge government focus now, obviously, on the workforce health issue. Obviously, they have to concentrate on a long-term bill, how do you get them back into health? I don't know, Elizabeth, if you want to switch it.
This is something that I think is really valuable when talking to businesses, is that the long-term value, the dividends we're going to see in that other places. It actually might show up in housing, it might show up in transport. Be very clever about how we deliver that business case. We have all the evidence. I honestly don't think we need more evidence demonstrating the return on investment, the value of investment, stock market performance, research and making health and productivity management. So I personally like to see, and I could talk tomorrow on this, is that the strategy in developing the data frameworks have to link to financial performance. So and that's a skill set, it's a mindset shift, and it's also can be demonstrated in the dashboard. So linking to all these connectivities, and we have to be better at communicating that to C-suite. So happy to have them.
Yeah, you guys should talk.
Yes, thank you.
I'm going to close there. I know you've got a question, but we have to run out of time, but we can take your question offline, finish. But just a point, we're doing some really interesting work on neighborhood health, which of course, to your point, that there is the direction of travel to devolve NHS spending to the regions, the neighborhoods, etc. We have more control over the situation. And it's a step in the right direction. Yes, so we're going to close there. Thank you so much for coming. We will hang around a bit to answer some more questions and network, etc. We do have the room for a bit longer. Apologies for starting late. Technology is always the bane of everyone's life, but we've got there in the end. So thank you, Richard, for persevering.
Thank you all for
coming.
coming.
Thank you, Richard, for hosting.
Like I said, there are questions online as well, which I will share with.
We will, if you can share them with me, we'll try.
One was for Whitney, and Whitney answered it online,
Okay.
so that's great.
So the technology work there, which is brilliant. Thank you to all my panelists, and most of all, thank you to all of you for coming.
Thank you.
Thank you for those who joined online. Thursday.
Sorry.
Well, let me stop this first.
Sorry, I will need to run then, but if you're in tomorrow, right?
Let me just stop this.